Good morning, everyone, and welcome to day one, session number one. We're very excited to introduce the topic of new advancements in colorectal cancer treatments. We're living in incredible times as science is quickly advancing colorectal cancer treatment. This session will explore new therapies, new interventions, and standards of care on the horizon and how these new advancements are being applied to your personal goals of treatment to achieve the best outcomes for you. We're very privileged to have a very profile panel with us today, and I'd like to introduce everyone before we get into the conversation. Dr. Jonathan Loree is a medical oncologist at BC Cancer who treats cancers of the gastrointestinal tract and is an assistant professor at the University of British Columbia. His research interests are focused on biomarker development, genomics, and liquid biopsies to guide therapy selection. Dr. Joanna Gotfrit is a medical oncologist at the Ottawa Hospital Cancer Centre and an assistant professor at the University of Ottawa. Joanna's specialty is in gastrointestinal and head and neck cancers. Her research focus is also in health systems and health policy. We'd also like to welcome Suzanne Wood, who was diagnosed with stage 4 colon cancer in July 2022, fairly recently, at the age of 45, doing a routine annual health physical. Thankfully, her tumors were deemed resectable, and she started on chemotherapy to shrink the tumors in preparation for surgery. She had a right hemicolostomy and a major liver resection late last year. Post-surgery CT scans identified a large tumor on her right ovary, and this tumor, as well as both ovaries, were removed earlier this year. Suzanne is currently undergoing adjuvant chemotherapy, and her oncology team are using ctDNA tests to help guide her treatment plan. And finally, please help us welcome Michael Groves, who is a senior program advisor, sustainability, and international mint liaison at the Royal Canadian Mint. He is a professional engineer and a graduate of McGill University. Michael also wants us to know that he is an avid Ottawa Senators fan and is proud to have completed 9 marathons. Michael's going to tell you about his own cancer situation. So welcome, everyone. Thank you so much for being with us today. I'm going to ask you, Suzanne, first to tell us a little bit more about you. Your story is quite incredible, and I know that our community will be very keen to hear more from you.
Well, thank you so much, and thanks everyone for joining us today. So you've got sort of the high level of what sort of happened to me over the last 10 months, but I definitely feel incredibly grateful to have been diagnosed at the time that I was. I was, very fortunate that my employer pays for private medical reviews, and so I had an annual assessment. And it had been about 15 months since the last time that I'd had a medical done. I knew at the time that I was anemic, but everyone sort of assumed that, as a perimenopausal woman, that probably was what was going on. During that medical, they do a routine ultrasound, and it was there that they discovered actually the metastases to my liver. And I was very quickly followed up with an urgent colonoscopy. And that was literally 4 days after I had had the ultrasound done. And that afternoon, I was referred to the oncology clinic at the Odette Cancer Center here in Toronto. And then things went really, really fast. And at the time, I think I thought it wasn't going fast enough because, like many of you in the audience, you're so anxious to get this cancer out of you, but you don't realize that there's lots of other things that have to happen behind the scenes. And that's really come to light to me as, I've progressed through this journey. So the first thing that my team did was, obviously do all of the biopsies were sent off. It was the surgeon initially who did the colonoscopy who said, we're going to send it obviously for biopsy, but I'm pretty sure this is cancer. And she unfortunately was right. I met with the oncology team, my medical oncologist initially, and the first thing that we needed to do was the CT scans. And so those CT scans were to assess whether or not my cancer was resectable, which, as you've heard, thankfully it was. The 7 lesions that were on the liver, one of them was actually very, very close to a couple of the veins. And so they decided we really needed to go through some chemo to shrink the tumors so that the surgeries would be more effective. I am constantly amazed at science being so phenomenal because I was sent initially to the University of Western Ontario to do some genetic testing before I went through the FOLFOX treatment, because they were able to do an assessment based on my DNA. And I'm going to leave it. I'm sure the doctors are going to weigh in on this and give you more background. But they were able to assess whether or not my body would be able to metabolize the drugs, the FOLFOX treatment. And that assessment came back normal. And so they were able to personalize my dose based on how it was expected that my body would respond to the chemotherapy. I started with the FOLFOX treatment and had 2 rounds before I developed some pain in my shoulder and into my jaw. So some assessments with cardiologists determined that it was likely that I was actually having some heart spasms resulting from the chemotherapy. So we switched over and I started on some Tomox treatments. Those went, I had 2 additional treatments, and then I was ready for surgery. So in November of last year, I had my right-sided colon resected. I then recovered from that. It was actually a laparoscopic procedure, so I was very, thankful that the recovery for that was quite easy. Easy, obviously, is all a relative term when you're in this journey. Then in December, I had a major liver resection. So they removed the middle portion of my liver, which left me with 2 little baby livers that then sort of grew back again. Science is so phenomenal. I don't know how that's even possible. So I was in a really good spot, we felt after that second surgery, and really felt that, we got it all. So we had really good margins on both of those operations. And so I met with my oncologist and my surgeons, and we discussed whether or not it made sense to explore ctDNA testing. And I know the doctors are going to talk a little bit more about what that is, but it was something that I had heard about at a conference. And so I thought, well, I'll just ask my doctor if that makes sense. And so we did go through and talk about whether or not that was something that was, could be used as one tool in my treatment plan. And we decided to go forward with that. So I had the initial testing done in late December. And that was organized through Life Labs here in Ontario, but is done, as many of you know, in the US. So I was feeling pretty good. We had, the surgeries were done. We were talking about doing a little bit of what I call cleanup chemo, just to make sure we got everything out. Had sent off the ctDNA tests, and I went in for follow-up CT scans. The CT scans unfortunately came back before the ctDNA testing, and we had identified a very large Krukenberg tumor on my right ovary. And a Krukenberg tumor, as I understand it, is an ovarian tumor that actually comes from a primary cancer in the gastrointestinal tract. And, that really, I have to say, threw me out of the whole process. That was the moment where, you really kind of got a sense that, oh, this could go in so many different directions. It came out of nowhere. And it was, by the time it was removed, sort of a month later, had grown to the size of those coffee bean bags that you get at Costco. So it was a 2 kilogram, mother of all tumors. And on the previous CT scan, it was actually only 2 centimeters. So that was, I think I was discussing with my husband, and I actually think that was a really good moment for me looking back, because it shows you just how, sideways things can go when you are in sort of a stage 4 situation. But luckily, that was removed along with my ovaries in February of this year, and I had a good recovery from that. And I am now back in chemotherapy, just going along with the cleanup crew again. um, and we'll have some new follow-up scans coming up. I also 2 weeks ago had a follow-up ctDNA test done, and that came back negative. So that's a positive sign, and my CEA numbers are now also in the normal range. So we're sort of seeing some really good signs of progress as we go. So that's sort of the high-level overview of what has happened.
Thank you, Suzanne, very much. And I have to say that you're incredibly educated, incredibly articulate on a lot of deep science. So well done in doing your homework.
Well, it's interesting you say that, because I know that for lots of people, they really like to get knee deep in this and do the research, and that's very helpful for them. It normally for me isn't. So I am doing a lot of sort of post research because I think it is really challenging, as you're going through it in the moment.
Yeah, thank you for understanding that. And we're going to come back in that. And I know that both of our oncologists will have many, many comments in response to the your story and your treatment. I'd like to first go to Michael, the Ottawa Senator fan, to talk about his story and his journey through cancer thus far.
Thank you. Thank you very much. So my story starts back, we'll go back to January of 2021. And it was a cold winter day here in Ottawa. And I was having a stomach issue, sore stomach. And my concern was that it could be appendicitis. My sister had appendicitis. And I know that something has to be looked at quite urgently. And it was, we're in the middle of COVID, and, the hospitals were definitely a place we wanted to avoid, but I did not want to take the risk. So I went to the emergency and had a CT scan, had blood work done, and I was diagnosed with diverticulitis. So it looked like something that, relatively minor, I thought, something I could live with and perhaps change some nutritional habits to adjust to. But a week later, I had blood that was in my stool. So I called my family doctor and just, I wanted to make her aware of this and try to understand if it was related to the diverticulitis and if this was a concern. So she said, you know what, it's probably nothing to worry about, but you're approaching your 50th birthday, and we'll do a colonoscopy, and I'll set that up. So we fast forward to April, so 3 months later, and I went for my colonoscopy, and this was on a Tuesday, and went through the procedure and woke up from the procedure and met the gastroenterologist, and she said, unfortunately, we found a tumor and I couldn't finish the procedure. So that was a total shock. I had been, exercising regularly. I hadn't had any other pains since my January episode. Nothing was going on for me. So quite shocked by the news, to say the least. But things moved fast. On the following day, I had a CEA, a blood test for CEA, and I had no idea what that meant. But anyways, I went for the blood test, and it turns out it was a 62 CEA, which I would later understand to be quite high. On the Thursday, I was already meeting with a surgeon, and he went through some of the, what this could be, but he was quite confident that would require surgery. The following day, the Friday, I was in for a CT scan just to see the, if there had been spread. And the results from that, so it was a difficult weekend. The results, he presented those to me on the Monday. and unfortunately it had spread to 2 lymph nodes. But fortunately, it had not spread anywhere else, at least according to the CT scan. So the surgeon was quite optimistic, and the procedure for the surgery was planned. And just over, I'm going to say about a week and a half later, I was in for surgery, and about a 5-hour procedure, and they removed 30 centimeters of my colon, and of course the tumor. And the pathology results came back shortly thereafter, and it was identified as a 51 millimeter tumor, which is what I understand to be quite big. And it had indeed spread to 2 of the 16 lymph nodes that were taken out. So the news was basically a stage 3B colon cancer. And the surgeon said, look, we'll pass you on to the colon cancer experts. So I was meeting with an oncologist shortly thereafter to walk through the plan. Again, there would be a delay from the procedure of the surgery. They wanted me to recover from the surgery to be ready for the chemotherapy. In the interim, between the surgery and starting the chemotherapy, I had noticed a mole on my side, and it ended up, this was discussed with my family doctor, it ended up being melanoma. So it was a bit of a step back and a setback on my side, totally unrelated to the colon cancer. However, because of this melanoma, I was ineligible for a trial that I was basically signed up for, because you can't have had cancer in the past 5 years to qualify for a trial candidate. So quite upset that I wasn't going to be part of this trial, but nonetheless maintained a positive attitude and began the chemotherapy in late June of 2021. So I was set for the 6-month, every 2 weeks, FOLFOX program, and this was something that that the oncologist did provide me different options: Kpox, which would be less intense, or the 6-month FOLFOX program. And I said, well, you know what would you recommend? And she said, no, you should, the 6-month is what I would recommend for you. We're going to put, the maximum amount of, efforts in this chemotherapy to ensure the best chances for success and outcomes. So I did that, and, the chemotherapy was difficult. There was the nausea and the different repercussions from that, and towards the end, the 11th and 12th rounds of chemotherapy, my neutrophils were low, and I missed a treatment, was delayed a treatment because of that. So all those things, made the treatment itself quite difficult. The neuropathy towards the end was quite substantial, and even to this day, a year and a half later, I still have issues on the neuropathy. So, but all in all, a month and a half after the treatment, I was able to gradually return to work. And, over time now, we've been a year and a half into this, and I've had regular CT scans, blood tests, and the CEA dropped. It dropped immediately after surgery from that 62 down to the normal levels, and has remained there ever since. So that's where I'm at, and looking forward to seeing what the experts in the field have to say for the new advances that are happening in the field of colon cancer research, and specifically on some of the tools that they have or are developing that will help perhaps mitigate some of the treatments that might not be required if some of the testing can show that it's not needed.
Thank you, Michael, for sharing the details of your particular situation. And we're now going to bridge into a discussion with the oncologist that we have on our panel today. And I'd first like to start with Dr. Gotfrit to really talk about general approaches to treatment, which are so personalized in many, many ways these days, as evidenced by the two stories we've just heard. So I'm going to ask for your comments on both Suzanne and Michael's journey.
Yeah, thanks so much. So I thought I'd start by talking about the approach to early stage colorectal cancer, because even that is becoming increasingly personalized. Um, the way that we approach early stage disease is essentially divided into stage 2 and stage 3. So just right off the bat, early stage disease is quite different depending on whether lymph nodes are involved in the tumor or not. Stage 2 means there's no lymph nodes involved, and stage 3 means there's at least one lymph node involved. But it's a lot more complex and more individualized than that. So all of these patients with early stage disease, as long as they're healthy and want to go forward with it, will initially be treated with surgical resection. That would be the standard of care. But we know in some patients they have a relatively high risk of recurrence, and that we can reduce the risk of recurrence by using adjuvant treatments, mainly chemotherapy. And in the world of stage 2 disease, this has actually been a very controversial topic over the past several decades. And we've never had studies to tell us definitively that adjuvant chemotherapy helps improve outcomes in stage 2 disease overall. That said, from the personalized approach, we do know that patients who have certain high-risk features, either clinically or in their tumor itself in the pathology specimen, can benefit from adjuvant chemotherapy, which would be 5-FU-based treatment, either capecitabine or sometimes FOLFOX or CAPOX. And those high-risk features, some of which are pathological, so if they have a very high-grade tumor or poorly differentiated, which is something seen under the microscope, a measure of basically aggressiveness. If they have a T4 tumor, which essentially means it's penetrated very deeply through the bowel wall, right through it, that's a high-risk feature. If inadequate lymph nodes were taken in the surgical specimen, that's a high-risk feature because there could be stage 3 disease that we don't know about as a result. If it looks like under the microscope, the cancer cells are trying to infiltrate into the vessels or into the nerves. So that's lymphovasculation, perineural invasion. Those are also high-risk features. And then clinically speaking, if patients present with a bowel obstruction or if they have a perforation in their bowel at the time of their cancer presentation, those are also high-risk features. And so we use those high-risk features, one or more of them, to really assess individually, would this patient potentially benefit from adjuvant chemotherapy and which adjuvant chemotherapy they may benefit from. In the setting of stage 3 colon cancer, the role of adjuvant chemotherapy is much more defined and definitively proven in multiple trials. And this is an area where we've seen some really good advances in the past few years that I want to highlight. In the past, until fairly recently, for patients with stage 3 cancer, it was standard to give 6 months of chemotherapy across the board. And this was for patients with all risk levels of stage 3 cancer. And the chemotherapy was usually FOLFOX or CAPOX, as long as patients wanted it and were able to tolerate it. But we had this really, I would say, breakthrough trial in the past few years called the IDEA collaboration. And this was a trial that assessed if we could use different duration of chemotherapy to achieve the same benefit. And this was such an important trial because we know with increasing the amount of oxaliplatin-based chemotherapy, we start to run into a major issue, which is neuropathy. And this is a cumulative side effect. It can greatly impact quality of life with numbness and tingling in the hands and the feet, sometimes painful, sometimes impacting people's day-to-day lifestyle. And as you give more and more oxaliplatin, you run into a higher risk of causing a permanent neuropathy. So the IDEA trial was so key because it assessed in patients with stage 3 cancer whether we could achieve the same benefit from using 3 months of chemotherapy instead of 6 months of chemotherapy. And the results of this are a little bit complicated, but overall, we found that in patients who had lower risk stage 3 cancer, we could achieve the same benefit with 3 months of CAPOX as we can with 6 months of chemotherapy. And the lower risk stage 3 group was defined as patients who had a tumor that wasn't quite penetrating all the way through the bowel wall, and for patients who had between 1 and 3 lymph nodes positive and not more. So for a very large subset of patients with stage 3 cancer, we now know that we can achieve the same maximal risk reduction with 3 months of CAPOX rather than giving them 6 months of chemotherapy. And we know from the study this reduces the chance of neuropathy about 3-fold. So that's a huge quality of life benefit for people, and we're very grateful to have that data now to safely give less chemotherapy. So I would say that's one of the big advances that we've seen in the past few years with regards to localized disease.
That is, and that is all a result of something you've called the IDEA trial, IDEA collaborative
Collaborate.
trials. Yeah, very good.
Yeah.
And is this, in terms of standard of care, does this apply to everyone, Dr. Gotfrit, or is there uh, any kind of testing or process that one would have to go through before you? It's like a balancing act between duration and type of care or the drug. How does that happen for people?
Yes. So that's a great point. So we try to be as evidence-based as possible whenever we make these decisions. And so we go by what the trial used to define the risk groups. And essentially only in the risk group that were low risk stage 3 cancer. So that was based on the tumor itself and the number of lymph nodes involved, which was classified as low risk. Those patients then get an equal benefit from 3 months versus 6 months, specifically of CAPOX chemotherapy, not FOLFOX chemotherapy.
Mm-hmm.
So
Mm-hmm.
we really base it on the pathologic criteria because that's what the evidence told us to do. That all said, cancer treatment is highly individualized. There may be patients that have very specific other features in their tumor, in their presentation, that themselves and the oncologist may discuss as very high risk, and that may change the way that they approach the adjuvant chemotherapy decision. May give more in that scenario. That would be an individualized decision. And on the same
Mm-hmm.
note, these chemotherapies like CAPOX or FOLFOX are doublet chemotherapies. They're 2 agents, and not all patients want to take 2 agents of chemotherapy. Not all can tolerate 2 agents of chemotherapy. There's also room to discuss doing single agent adjuvant chemotherapy like fluorouracil or capecitabine on its own. That would again be an individualized decision. So certainly it's not across the board that every patient should be treated the same way, but we do use the evidence to come up with our standard of care treatment and then tweak that for the patient sitting in front of us based on their own situation and of course their wishes as well, which of course come into play.
Right, right. And I was going to just ask you to close on that comment is how does that conversation actually get initiated? Is it a singular conversation? Is it a conversation that's informed over a period of time? So for, members of our community who are assessing the kinds of treatments with their own oncology teams, what kind of things can they expect from a conversation that will help guide the choices they make for themselves?
Yeah, so, I would say any conversation about a proposed treatment should include the benefits of the treatment, the risks of the treatment, and the alternatives of the treatment. These are really important questions for people to ask. These are the things that physicians should be bringing up. And so these decisions will often be made very soon after a surgical procedure to remove the main tumor. People may still be recovering during that time. They may take place over several weeks, but ideally we do like to start these treatments within about 8 weeks of the surgical operation. And so I think it's key during that time that patients and physicians have that discussion of risk, benefits, and alternatives in order to make that decision sooner rather than later, because we do know timing matters with initiation of adjuvant chemotherapy.
Yeah, thank you so much for saying that. In both Michael and Suzanne's case, I was very taken by how quickly both of them moved through treatment. So it was quite impressive, I have to say. Dr. Loree, I'd like to bridge now and bring you into this conversation. There's been some language used here that may not be familiar to a lot of people, specific around this idea called ctDNA. Maybe you want to help us understand what that is. Does it apply to everybody? Is it new? What exactly are we talking about?
Yeah, thanks for that. So ctDNA is a way that we can find traces of the cancer in the blood. It stands for circulating tumor DNA, and all of our normal cells, as well as cancer cells, whenever they divide or if they're dying and being replaced by other cells, they can shed some of their DNA into the blood. And that DNA was something that was very hard for us to detect a long time ago because there's so much more normal DNA in our blood. But we've gotten better at sequencing and had advances that allow us now to detect very small amounts of that DNA that give us an idea about what's going on in a person's body right then. And so we try and use all the information that we have available to us about a patient's health, about features that we see under the microscope, like was the cancer in the lymph node. But a lot of those things are kind of looking in the past, and ctDNA is looking at what's happening right now. So when a patient has a blood test taken, that DNA is only staying in the blood for about 2 hours before it breaks down. And so it means that if we're seeing something, it's not that the cancer was there 2 weeks ago and it was cut out shortly after. It means that the cancer is still there potentially. And so we want to use this as extra information to try and help improve outcomes. It can give us different information. We're hopeful that in the future we can use circulating tumor DNA to detect cancers earlier, so as a new screening test. Right now, screening tests often use a test that looks for blood in the stool or a colonoscopy, but maybe this could be something new that can find it earlier. The other place is after someone's had a surgery. This can give us an example of, we call it minimal residual disease. And what that means is that when we look at someone's body with a CT scan, we're looking to see if we can see the cancer anywhere. But cancer, it can spread and only have a few cells somewhere. And if there's only a few cells, we're not going to see it on the CT scan because it will be very small. And this might give us an earlier bit of information or some extra information about really small amounts. And the goal there is to say, well, we can't see it on the CT scan, but we know that because we can detect it in the blood, there's a really high risk of the cancer going back. And studies have shown that if we can detect ctDNA after surgery, that risk is really high. And so that gives us, again, more information, not just the lymph nodes or how deep did the cancer go, but a sign of, oh, the risk is high. It's a warning sign. Maybe we can do something extra. It can also tell us something else, and it can tell us that maybe the risk is lower for some patients. You heard from Dr. Gotfrit about how neuropathy can impact patients a lot long term, and that can be something that is important in decision making. And we've now been able to move from 6 to 3 months of chemotherapy for many patients. But there might be even more patients where we're able to limit side effects if we know that the risk is even lower. So that's kind of the second space where we're using ctDNA. And so that's to help inform this decision making around surgery. And then the cleanup crew that Suzanne mentioned, how much cleanup crew do we need? We're still learning how to use ctDNA, and there's a lot of trials going on in Canada right now because we know that it's prognostic. And what that means, when we say the word prognostic in cancer care, it means we know that something tells us the risk of the cancer coming back is higher or lower. But the really important part that we're still generating data on is whether it's predictive. And what that means is there a way that we can act on that information that will change the outcome for a patient? And how do we act on that information? Information is really powerful, but knowing what to do with it is the next step. The third kind of realm where we can use ctDNA is if a cancer is metastatic and we want to learn about what vulnerabilities it has. So if it's got certain mutations we can target. And that's something that we can also test for with this ctDNA. It's done in a slightly different way because there's a lot more DNA in the blood when the cancer is metastatic because the tumors are bigger. But again, more information that we can have. In Canada, there's 2 trials that I want to bring up. Actually, there's 3. So in stage 2, so if the lymph nodes don't have cancer, there's a trial going on right now that's looking at the use of ctDNA. What happens is patients are randomized, and half of patients would do what they would normally do anyways with their treatment, and the other half have their treatment informed by ctDNA. So they're given the result, and if the ctDNA is positive, we would recommend more intense chemotherapy than normal. And if it's negative, then we would basically say you don't need chemotherapy because the risk is really low. We did just finish recruitment for a trial in Canada for a trial called Dynamic 3. It was done in Canada and Australia. And that was looking at using ctDNA to either intensify treatment or de-intensify treatment. I think that's a trial that Michael mentioned. It was really exciting to be able to offer that to patients, and it is completed now, but we're really excited to be joining in another trial that called Circulate US, or in Canada it's going to be called CRC 10, and this is going to be going to the next step. And in Dynamic 3, our question was, could we make it less intense, the chemotherapy? in Circulate US, the next question is, can some patients completely avoid adjuvant chemotherapy if they had a lymph node that was positive, if there's no sign of ctDNA? And then maybe we can follow with the ctDNA after surgery and really quickly treat if there's a sign the cancer is coming back. So if you are interested in learning more about those trials, ask your oncologist during any of your consultations. It's something that would be kind of done initially after a surgery when that first decision around that cleanup crew chemotherapy Suzanne mentioned is done. It's not really something that would be done kind of a couple of years later, but it's always an evolving space, and we're really excited that ctDNA is moving towards the clinic and we're able to start generating more data.
Yeah, so because this session is all about new, novel, what's on the horizon, is this the silver bullet? Is this the newest, latest, biggest thing that everybody really is talking about?
I would look at it as another tool, and I think we're all really
Another
excited
tool.
that it's going to help improve outcomes for patients,
Mhm. Mhm.
and it's
Mhm.
going to help us reduce the risk of the cancer coming back, but it's also going to allow
Yeah,
us to use less therapy in some patients. Sorry, I'm getting a lot of
perfect.
feedback. Are you guys hearing that as well?
We're good. So we'll forge ahead here, Dr. Loree, and keep going. So Suzanne, maybe I'll bridge to you because what was your experience with ctDNA, and in what context, and how did it help you?
Yeah, I think it's sort of helped me in a couple of different ways. Obviously, when I first went and had the first test, we all had expected it to come back negative, and were disappointed when it didn't. But the good news that it didn't is that it turned out that I had a big tumor, right? So I think that for everyone on the team, we're like, okay, phew, like at least we know it's finding stuff. Obviously, that's a big help. And then having my follow up where it has gone to zero already is it's a weight off for sure off of my mind. I think there's a peace of mind aspect where I think that it's helped me to see that I'm in a good spot, and we're progressing well, and that the treatments are working. I would expect that I'll have sort of a follow up in the next couple of weeks because I am still continuing with the therapies now. The big sort of elephant in the room, I think, for most patients is that this is not covered by any of our provincial healthcare system. It's not covered by, private insurance currently in Canada. Though I have submitted a claim, so we'll follow up on that hopefully. I think it is a huge benefit to patients and to the team to have the additional information, right? It is not, I don't think, a silver bullet. I wouldn't want any, I'm certainly not trying to say that it's been a silver bullet for me as a patient, but it definitely has helped to guide, this sort of after phase that I'm in, looking at, how much cleanup are we going to need? We did not get, the zero and say, okay, well, we're going to stop, right? And partially, I think that is because of my Krukenberg tumor. I'm blaming everything on that. But I think it would be a different scenario if it hadn't sort of spread as throughout my treatments. Maybe you would have stopped. I don't know, but it certainly does help to guide the chemo going forward. I'm tolerating the chemo quite well, and so that I think is another piece that goes into the picture. If I wasn't tolerating it well, we'd probably be having a different conversation, and the ctDNA would be a really critical piece to that conversation.
Mhm. Thank you for sharing that. Michael, I understand that you've also, as part of your therapy, asked for it, and there was some questioning around it. Maybe you could share your experience with it, and our two oncologists can comment there. Oh dear, Michael, we cannot hear you. Are you on mute? I'll give him one more moment. What I have understood here was that Michael actually had asked for, or it was part of a discussion he had had for ctDNA testing, but told that it wasn't available fundamentally, and there was folks who really perhaps didn't know how to interpret the results or what to do with the results. Given that this is so new, I can certainly understand why that might be the case, but maybe Dr. Loree, Dr. Gotfrit, you could comment on that.
Yeah, I think that raises, we've had some really good discussion points here about ctDNA as the tool. And I think it's important to talk about all the tools that are available to both yourself and your clinicians and your physicians when making decisions. And there might be a reason that they're thinking that tool might be not useful in a certain case, or as was mentioned, it isn't something that's covered right now. And so those costs can also be quite prohibitive. I think one of the challenges that we have right now is that, healthcare is very expensive and we need to help make sure that we're making the right choices. And if a ctDNA is positive, oftentimes the next test would be a CT scan. So if we're ordering a CT scan anyways, then maybe the ctDNA isn't needed right there. So in Suzanne's case, there was a mention of a ctDNA test not being back, but the CT scan showed that the cancer was back. So that test right there was maybe not an added value for the patient to pay, because it is quite expensive because the CT scan was being done. So I don't know the specifics of Michael's case, but it might have been that there was something like that. I think people are really excited about that decision point right after a surgery. So we call that a landmark time point, that ctDNA after surgery. What's the risk of the cancer coming back? We're still learning about surveillance, how much value there is. There haven't really been studies showing that doing surveillance ctDNA instead of CT scans or in addition to CT scans and CEA catches more cancers. There's actually been a few studies showing that it caught about the same amount. We hope that it will. It certainly seems a lot better than CEA, and we're all really excited to do it. This is part of why research is so important, because we need to show that it does catch it earlier. And then we also need to build the data that's important to get the test reimbursed in the provinces. So that way, this is something that there's more accessibility to. And in doing that, we also try and do it in a way that makes the most sense so we can provide the most benefit to most patients with the test.
Yeah, thank you for your comments on that. Welcome back, Michael. I want to give Dr. Gotfrit the final word in this space before we wrap up the session. Any comments you would like to make?
Sure. Yeah. I'd like to say, with the advances that we're seeing in colorectal cancer and outside of it as well, the topic has been brought up, and I think it's really important, the access and the funding of these new novel therapeutics. Sometimes they're drugs. In this case, we're talking about a test. And I would say, art of research is how much data is enough data to say that we've proven something is successful. And that's really, no science can ever tell you that answer. How many trials and which trials are enough to tell you, yes, this is now the standard of care, it's time to implement it. This is actually something where I would say as a community are challenged with in drug approvals, test approvals, all sorts of different areas of cancer care. And one way that many groups are trying to advocate for is in the more rapid access to these novel therapeutics and novel testing strategies. Because as Dr. Loree said, they are very expensive. We also want to use them safely. We want to use them accurately. We don't want to adopt them too soon either, because the first thing we all learn in med school is first do no harm. We want to make sure that it's the right way to go before we implement and before we ask our funding bodies to fund. So this is a very, very fine balance for us. This is something many groups are advocating for. And I think as we get more and more novel strategies, novel drugs, novel tests, it's going to become something that we all are more and more aware of, and we'll just see how the future unfolds.
Yeah, thank you so much for those rather passionate comments. And I will also suggest that patient groups like Colorectal Cancer Canada are very forefront in terms of advocating for increased access to new therapies. We're very, very grateful for the time all of you have spent today. I'm going to give the final word to Michael, who I'd really love, Michael, for you to just answer the question. I mean, what advice would you give to someone who's just been newly diagnosed with colorectal cancer, but of course, cancer in general?
What my number one recommendation would be to listen to your well, I've got two. One is, listen to your oncologist. They're always right. They're on your team. They're doing everything for you. But number two, join a support group. One of the first things I did was look up the information from Colorectal Canada, and they had support groups. I joined a support group, and I learned so many ins and outs from that's the support group that I attend on a monthly basis. I don't attend every month, but I go as much as I can. And the information that you get from your, everybody else, the caregivers, but also the people going through what you're going through, it's really important, and it allows you to ask those questions to the oncologist while you're going through the treatment, and you're sharing, everything from the neuropathy issues that you'll suffer from, to other, how to navigate the hospital systems, and everything from what to do on the good week. You often have a good week following your chemotherapy. What people do on the good weeks and what they do, on the more difficult weeks. How do you keep your mind busy, and how do you remain positive throughout? So that, and I continue to go. It's been a year and a half now since I've been through my treatments, and I'm providing some of my learnings to the people that join the group, and they really do appreciate the feedback that we can give them as survivors.
And we're very grateful that Suzanne and Michael, you shared those perspectives. Outside of I agree, oncologists are superheroes, in my opinion. So thank you to all. I know we've covered a lot of different topics today. I want you to go to colorectal cancer's website and look under something called Tush Talks, where we talk a lot and have a lot of information about specific topics related to various different issues related to cancer, of course. But there's one particular that talks about metastatic stage 4 cancer, which we really didn't touch on a lot today. And it's a session by Dr. Burke that I think our audience would really value. So with that said, we're going to end the conversation and open up to our community for questions for anybody on this panel. Thank you so much. We are very happy to welcome our panel back for an open-end Q&A. I have the great privilege of seeing what are dozens of questions that absolutely were coming in throughout the conversation. And so I'm going to kick the session off with the very first question. And Dr. Loree, I'm going to go to you because you started to touch on the fact that ctDNA was a tool. And the first question here coming from Angela and our audience is, can ctDNA be used as a tool to detect early recurrence in patients who are deemed NED, but still undergoing active surveillance? So I can read the question again if that's helpful, but I think because you talked about ctDNA being part of a toolbox, I'd love if you'd answer that question.
For sure. This is one of the areas that we hope ctDNA will really help improve outcomes. Right now, surveillance typically consists of CT scans, some sort of scope, whether it's a sigmoidoscopy or colonoscopy, and a test called a CEA. And the CEA is kind of an old blood test that doesn't work very well, and we're hopeful that that will be replaced with ctDNA. The studies suggest that ctDNA can detect cancer earlier than CT scans in some patients, not all. Sometimes the CT scan is the first thing that might be positive. But we haven't seen a lot of studies done yet that show kind of what's the optimal way to use it for surveillance. How often should it be done? Is there a certain risk group where it makes more sense to do it? And so we're still learning about the optimal situation. But yes, for surveillance, it's definitely a tool that will hopefully help improve outcomes in the future.
Thank you. Dr. Loree, I'm hoping you'll let me put you on the spot, and I appreciate if this is not a question you want to answer, but both of our oncologists might be in a better position to understand the next question is, do we anticipate public funding for ctDNA? I know that Suzanne mentioned it was one of the barriers for sure. And if you're comfortable answering that question, that would be terrific.
Yeah, I think it will, but I think we need to generate the data first. And currently, it's been a lot of what we call retrospective studies. So it's samples that were collected and then analyzed after the fact. And that's usually not the type of study that we use for reimbursement in Canada. We use data from randomized clinical trials. And we have those open in Canada. So we've just completed one for patients who have resected stage 3 colon cancer, and we're starting another one in collaboration with the Americans. So that's Circulate North America. That'll be opening across Canada shortly. We just finished one called Dynamic 3. And we have one for stage 2 colon cancer called COBRA or CRC9. So we're in the middle of generating that data. Those trials are also good opportunities to often get the test covered. So for Circulate North America, the test will be covered for patients with stage 3 colon cancer. So it's a way to generate data, but also provide access to the test.
Yeah. Thank you for answering what was a speculative question, but for doing so in a way that I think was very productive. Dr. Gotfrit, this question is actually asked of you. Dr. Gotfrit mentioned that if someone cannot tolerate a doublet chemotherapy treatment, they may be given a single agent chemo. How does the effectiveness of a single agent compare to the doublet or a triplet chemotherapy?
Yeah, so that's a great question. So it's usually in the realm of stage 3 cancer where we're hoping to be able to give doublet chemotherapy for most patients. In that realm, when someone cannot receive doublet chemotherapy either because of tolerance problems or the toxicity profile, and we use single agents in studies is about 2/3 as effective as the doublet. So in studies, we see about a 15% extra advantage to doing the doublet chemotherapy. And for those who get the singlet, which is usually 5-FU or capecitabine by itself, we see about 10% benefit. So most of the work is done by that agent, but we do lose a little bit of effectiveness when we have a single agent versus the double agent. That's a great question.
Yeah, thank you very much. The next question I'm going to ask, actually, I'll ask it from two perspectives. One is from the oncologist perspective. And the question specifically is, what do the medical professionals say about going for a macrobiotic diet instead of chemo for treatment? I'm going to ask both Michael and Suzanne to maybe comment if they had used any kind of food as solution or food as part of their treatment as a build on that question as well. So again, the question is, what do our oncologists say about going for a macrobiotic diet instead of chemo for treatment? So Dr. Loree, I'll go to you first.
Yeah, I think diet is a really important part of overall health, and both for cancer as well as for heart disease and for so many other aspects of our health. It's really important to have a good diet. I think using diet in place of chemotherapy is something I would be apprehensive of, because we just don't have studies saying that a change in diet is as helpful as chemotherapy when the risk is high of a cancer coming back. Now, the amount of chemotherapy we recommend really depends on the risk of the cancer coming back. And so maybe for a stage 1 cancer where we might not recommend chemotherapy, maybe there is a place where those diet changes. Exercise, I think exercise is also important. Those might be really important things to consider doing, but I would kind of be concerned about doing it instead of.
Yeah, thank you. Dr. Gotfrit, I'm going to suspect that your answer is similar, but if there's anything you wanted to add to that.
Yeah, I would just say, I see all these different maneuvers as complementary with one another, but not to replace one another. So, as Dr. Loree said, I fully agree. Diet is so important for overall health and for maintaining strength while on chemotherapy. And we know that there's risk factors within diet for development of future cancers as well. And so, minimizing those risk factors with the appropriate, well balanced, healthy diet
but I don't think that replaces the need for chemotherapy or the benefit of chemotherapy. I see them as complementary, not one or the other.
That makes a lot of sense to me, for sure. Suzanne, maybe I'll ask you, what was the role of diet for you? The importance of it. Is there any interesting things you could share with our audience around food? And Michael, I'll ask you the same question.
Yeah, I think that definitely the complementary piece is sort of what I have done. Because I've had so many surgeries, I've had these periods where I've lost a lot of weight and then had to sort of regain it. So been more focused on sort of maintaining my weight as opposed to, any particular forms of nutrition. And I think that the one thing that has been super challenging for me is almost the psychological piece of eating. I think there's a lot of pressure on cancer patients to eat perfectly and be very clean and very focused. And that's been a balancing act for me, in particular. And I know I've spoken with others about this piece. And so I think you have to make sure that it is, part of what you do, but not so solely focused on it that you then are having issues with eating, in addition to your cancer and treatment.
Mm-hmm. And Michael, what's been your experience?
Well, when you're going through chemotherapy, one of the last things, and I have a sister that's a dietitian, and she kept reminding me of the importance of eating well.
Lucky.
But during a chemotherapy, you're just there's days you just don't want to eat. So when you want to eat, you just want to eat something you like eating. So I think diet is on your mind, and now when you lose 30 centimeters of your colon, just getting that back in shape with the regular foods that you're eating is your first goal. But it is front and center, as well as exercise. And happy to report that neuropathy does impact your exercise, but as you do more exercise, the neuropathy wanes as well. So I think exercise and diet, it's in my mind and it's on my mind, and I try to do better, but it's a change of behavior too.
Thank you. I love the point that everything is complementary and everyone is an individual. There's still clearly a lot of interest in the topic of ctDNA, and the question here is, how accurate is ctDNA testing? If you get a negative ctDNA result, is that enough to say there is no more cancer in the body at that particular moment? Again, Dr. Loree, I'll go to you on this.
Yeah, I would say that it's not enough to say that there's no cancer in the body, and that's why we still need to do the other parts of screening, even when we're talking about a research setting. So, like the CT scan annually, that's part of surveillance. The tests, there's so many different tests available, and so beyond the scope of our discussion today to talk about kind of the sensitivity of each test compared to each other. But we know that some people, that probably about half of cancers that are going to come back have a ctDNA test that's positive at the landmark time point. So somewhere kind of 2 to 10 weeks after surgery, a blood test is taken and we look for the sign. But that means that there's still half of cancers that aren't detected. And we don't know if that's because the tests need to be better or if that's as good as we can get, because there's so little cancer in the body that just from a dilution perspective, that you just couldn't check all of the blood to find these small signs if there's only one strand of cancer DNA in all of the blood in someone's body. So we don't yet know that answer, and that's where hopefully the test will get better. I think that's where people see a lot of advantage of serial tests, where maybe there's one at 4 weeks and there's another one at 8 weeks, and so you're kind of doubling up on the chance. But we don't yet know that optimal strategy. Obviously, doing serial samples like that also adds to the cost, which
Yeah. There actually is a build on this question. And again, if we could continue to ask Dr. Loree, you've talked about the different ways that ctDNA can be used prognostically, predictively, identifying tumor vulnerabilities, et cetera. If you do ctDNA testing right now in Canada, would it be just for prognostic purposes?
There's different tests. There's some commercially available tests that are looking for types of mutations that we Dr. Godfrey and I would use to recommend a treatment. So that might be for things like a mutation in a gene called BRAF. So we can have that blood test and use that information and say, oh, we have a targeted drug that can go after that. That's usually in the metastatic setting. We call that genomic profiling, comprehensive genomic profiling. And then the other setting is in the early stage and trying to make that decision. I think, prognostic, that word means what's the risk of the cancer coming back? And that's really at the heart of the shared decision that an oncologist and a patient have around what chemo to do. We have kind of guidelines that say to do 3 months of chemo or 6 months, or sometimes we talk about single agent. But for each patient, the risk of the cancer coming back depends on how deep the tumor is, how many lymph nodes were affected. We also have to think about how the chemo might affect their other health conditions. If someone has lots of other health conditions, maybe doing more chemo might be detrimental because of the side effects. And so I think it's a way of getting more information. So it's predictive in a way that it can inform the discussion better moving forward. And hopefully we have the data in the future after these trials are done to say it's predictive and this is what we recommend. Again, it's still shared decision making and important to take into account.
Yeah, thank you so much. There's clearly a high interest in this topic. Also, what was re-triggered as part of the discussion we had around diet and so forth, there's another question here for our oncologist, which is, how do you feel about patient fasting to reduce chemotherapy symptoms? Dr. Gotfrit, maybe I could ask you to comment on that.
Yeah, so I worry a little bit about patient fasting while on chemotherapy. Back to what I was describing before, in the sense that chemotherapy, I describe it to patients as a bit of a marathon. It's tough, it makes people very fatigued. It comes with lots of side effects. And my view is that a healthy, well balanced diet is something that's really necessary to maintain your weight, to maintain your strength and ability to get through chemotherapy. I know that fasting has been shown to have various different health benefits in different avenues, but with regards to chemotherapy, everyone's different. It definitely needs to be individualized, but I would exercise some caution with regards to fasting because first and foremost, I think you want to maintain a good, healthy diet and maintain that strength and energy to get through chemotherapy.
Yeah, thank you very much. Yeah, that makes a lot of sense. So there's a question here that again is a build on that, which is enteratitis, I believe is how it's pronounced. Is there foods that are problematic for that?
I'm not sure I understand the question.
Yeah, I am not sure. I have not heard this term, enteritis. Spelled
Oh,
Enteritis. I apologize if I'm mispronouncing it. The question was, is there
it may
foods that are problematic?
It may be enteritis, like an inflammation in the digestive system. That may be the question. So
Yeah, and I'm very
chemotherapy,
sorry.
especially,
I had not seen this term either, but I thought perhaps, so it's spelled Enteritis. And if that's not correct, then perhaps we can move on to another question here.
I think each person has foods that work for them, and maybe I'll ask our patient partners to comment on what worked for them and didn't work. Sometimes it's a bit of trial and error, and each person's different in that they might have had a different surgery in different parts of their intestine or different amounts taken out, and so the
Exactly.
foods might be more challenging.
Yeah, I agree. Suzanne and Michael, I do want to leave the last word in the few seconds that we have left here because there is a lot of interest in what I call the management of body outside of, a lot of the drug treatments that one is receiving during cancer. I'll go to you first, Michael, and just if you could share some of your, I'll call it best tips for managing chemotherapy, managing treatment with our audience, that would be great.
I think just get out there and enjoy the fresh air when you can. It's the treatments itself are difficult. But going out, taking a walk, go as far as you can. Just get your mind. It helps you get your mind off things as well. And so that would be my number one recommendation for anybody going through the treatment right now.
Thank you very much. Suzanne, final word?
Yeah, I would echo that. I think getting out is really important, and also connecting with other people. So, if you can connect with, in your cancer center or through, different organizations, there are great, Wellspring offers a host of yoga online, which I did a ton of. So,
For you.
any of those things that you can stay active, I think is super important.
Yeah. Well, we're very grateful to Suzanne, yourself, Michael, Dr. Loree, Dr. Gotfrit. Thank you so much for joining us today. Clearly, this was one of the most important conversations we needed to have as the therapy and treatments are evolving in the field of cancer. So I'm sure we'll welcome you back to next year's session as well. Thank you for being here today. That brings us to conclusion on this session.